Here's a video that my partner put together with two of our residents. I thought it'd be worth just going through it because it shows a little bit of the setup. This is sort of similar to what Dr. DePatry showed on week 2 in terms of some of the sort of real life views. So it's just a couple of minutes long. I'll narrate a little bit. There's some subtitles here. But I thought this would be nice to have in the presentation when it gets archived, because I think it goes through the thought process, the setup, and a little bit of the anatomical nuance as well. So here's a classic aqueductal stenosis case, right? So the fourth ventricle looks pretty normal, pretty massive triventricular hydro, really good case for an ETV. We put the kids on a padded headrest. The incision is either right at the edge or just lateral to the edge of the anterior fontanelle. You can use the anterior fontanelle to gain access to the lateral ventricle in infants and babies who have patent fontanelles. We make a small vertical incision. Some people make a curvilinear incision. This is me videoing. That's Dr. Swadan on the left and Dr. Morgenstern, who's now faculty at Mount Sinai there. He was our chief resident 2 years ago. Accessing the lateral ventricle, we go directly in with the camera and sheath. Some people use a peel-away sheath. For less than large ventricles, I'll usually put a ventricular catheter in first and then follow that track down with the endoscope. But again, there's lots of variations on the theme, and as long as you know your anatomy and feel comfortable with your technique, those variations are just fine. So here's a nice robust vasculature coming off of the basilar apex, but certainly a clear interval there. That's the tuberostinarium. That's the interval between the basilar and the dorsum sellae, as you can see illustrated beautifully here. The PCOMs coming off the apex. Absolutely no question where the perforation would be made here. Again, we use the blunt perforating forceps from the endoscopic set. It's got a little bit of a rounded front, so even though we call it blunt, it does have a little bit of a rounded front to it. Making a tiny opening is all you need, and then placing that 3 French embolectomy catheter in there. You can see in the inset there that there's a small tuberculin syringe, which is filled with 0.25 cc's of water that we're just sort of inflating and insufflating and deflating to blow up and deflate the balloon. That creates enough of an interval to create the stoma. Here, because the baby had pretty large ventricles and the floor was thin, a little bit of a patulous nature is recognized around the floor. And so that's one of the risk factors for the ETV closing off. And so even though we don't do it frequently, doing a little bit of cautery around the edges of the stoma creates a little bit of a firmness to it and allows the balloon to have a little bit more tension against which to dilate. And that creates a little bit more of a permanency to the stoma. Again, looking down through the stoma to find the basilar artery and make sure you're through the membranes of Lilliquist, and then that the surgery is complete. There's a beautiful view of cranial nerve entering into the dorsum there. Coming back out, inspecting the fornix to make sure there's no damage or bruising, and then again inspecting the cortical mantle as you drive the scope through. Our postoperative assessment typically involves an MRI scan. We can get beautiful imaging now on MRI to look at the pulsatility of CSF. These are sort of these live cine MRI scans. The truth is that the intraoperative assessment of success is probably the more important of the assessment tools than the postoperative MRI scan. Just pause this for a second here. Very rarely does a postoperative MRI scan ever provide enough information to change a decision that you have not already made in the operating room as to whether or not a surgery is going to be successful. But it does provide at least a baseline against which future MRI scans might be compared. And so there's a philosophical argument about whether or not it's worth it or not, and how to follow patients with ETV, which certainly we can discuss in question and answer session. Typically we'll get an ETV as a post-op scan. Its utility, I think, is maybe a little bit questioned though.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.